Good afternoon, everyone. My name is Jenna Webb, and I'll be the moderator for this afternoon's call. We are in the radio room in the Legislative Building in Regina, and with me is Saskatchewan Health Authority CEO Scott Livingstone. Today's event will include a presentation and then also time for questions. So to kick us off, I will turn things over to Scott.
Thank you, Jenna. Good afternoon. Joining me today on the line is our Saskatchewan Health Authority Chief Medical Officer, Dr. Susan Shaw, as well as our Emergency Operations Chief, Mr. Derek Miller, and the Chief Medical Health Officer for the province, Dr. Shahab. I'd like to start by saying thanks to all the healthcare workers across the province, anybody working in the healthcare system who is making sacrifice each and every day as a result of the pandemic. We are grateful for all the hard work you do each and every day on behalf of people of this province. I'd also like to pass on my condolences to the families of those who've passed in the last 24 hours due to COVID-19. In some ways, I hope these untimely deaths increases our resolve as a province to help fight the virus. Today, we're going to provide you an update on the COVID-19 Health System Readiness Plan and also provide some more details on the pressures and challenges facing the healthcare system. I'm going to pass it over to Derek in a minute, but before I do, I'd like to provide some context for today. I'd like to acknowledge that currently our contact tracing system is certainly under strain, and there are some key drivers of contact tracing that we all know. It's not just the number of new cases each and every day in the province, but it's also the number of contacts per case. A single positive case each and every day provides hours of work for contact tracers over the 2-week time period post-positive result. But that work can grow exponentially when you factor in the number of contacts. As you all know, our rolling average of cases has been around 214 per day. If we take that over a 2-week period of time and apply the average number of contacts per case, it creates more than 32,000 hours of work for contact tracers in a 2-week period of time. Unfortunately, over the last month, some of our investigations have revealed that some individuals have as many as 150 contacts for a single positive case. With today's numbers, it's likely we're going to see more increased pressure. I'd like to highlight that this has real consequences, both for COVID response, but also non-COVID services in the health sector. When our workload increases, particularly when it increases quickly, we are required to redeploy staff and disrupt other services. When our staff get exposed to COVID in the community, to positive cases, we are forced to have them isolate, which continues to erode our workforce and threatening the provision of services, both COVID and non-COVID. Over the last few days, we've had a number of recent cases where 20 to 30 staff have been forced to isolate, which in some of the smaller facilities across the province, that would completely debilitate them with respect to providing any services at all. Some small good news is that we are seeing the average number of contacts slightly lower than it has been in recent weeks, but we certainly need to both decrease the number of positive cases and contacts if we're going to get ahead of this virus. We need people to shrink their bubbles, maintain social distancing, wear a mask, and ensure that they don't go to work when they're sick. With that, I'm going to pass it off to Derek to provide an update on the Health System Readiness Plan and again to highlight some of the pressures the system is facing. Go ahead, Derek.
Thank you, Scott. Good afternoon, ladies and gentlemen. Today I'm happy to go through a Health System Readiness update for COVID-19. Our purpose remains to be able to adapt and expand to meet projected COVID-19 patient demand, and while continuing to deliver essential services to non-COVID-19 patients throughout the duration of the pandemic, and this remains unchanged from previous updates. Today I'm going to walk through a few key points in order to provide a bit of an update on our current state and looking forward to the next few weeks and months and what that might mean for our system. I'm going to cover off key aspects of our strategy, which includes an offensive strategy and a defensive strategy, and then some of the challenges that we are enduring through implementation of those approaches. And then covering off a redeployment plan that we are in the process of implementing, as well as an accompanying service slowdown plan. So first up is the current state and forecasted growth. This graph depicts the number of active cases across the vertical axis and in time from the initiation of the pandemic across the bottom. And you can see in the last month the exponential growth of our total active cases, increasing by 363% over the last 30 days, and it's continuing to grow. As well as just in the last week, we've seen an increase of 1,000 active cases. This has a direct impact on our health system. We see it in our acute facilities with an increase in the number of hospitalizations up 383% in the last month, and that's continuing to grow. Right now, we have 35 COVID patients in our regular hospital beds in Saskatoon, and only 2 available ICU beds if their conditions deteriorate and they require admission into an ICU bed. The percentage of ICU capacity being used for COVID patients right now is 27%, and that number is increasing daily, and it's up from 5% a month ago, so representing a 5-fold increase on ICU cases. Looking into the future, and Dr. Shahab provided an overview of the modeling information that's informing our forecasts. If our current trajectory is left unchecked, we would see COVID acute care demand essentially accounting for half of all of our available acute care beds across the entire system over the next 4 to 6 month period. And likewise, for that same period, COVID ICU demand would be 5 times our current total capacity that we have in the system, and that would be enduring over the course of 4 to 6 months. These have massive impacts on our health system. I'm going to go through our offensive strategy. Our key goal is to contain, delay, and mitigate the virus and promote population health. There are many aspects of this that we're employing to achieve this goal. Today I'm going to cover off 3 key planks of the strategy that include testing, contact tracing, and protecting our vulnerable populations. The first area that I'm going to talk to is our testing strategy, and first I'd just like to draw your attention to the process that's outlined at the bottom of this slide, basically depicting our overall testing approach and process, which is typically initiated with a call from an individual to A11 where they would get a referral for testing. We typically achieve a 24-hour timeline to get a symptomatic individual in for a test. Asymptomatic, those that aren't displaying symptoms, the timeline can be up to 72 hours to schedule a test at one of the more than 50 testing sites across the province. Once a specimen is drawn, it's transported to the lab. Depending on where you are in the province, that transportation time can vary from as short as 5 hours in Regina to over 24 hours for some of our northern and remote locations. We do average about 17 hours of transportation time in the province. Once the specimen arrives in the lab, typically at RUH or at the provincial lab in Regina, we prioritize testing or the processing of those tests for symptomatic samples, and our turnaround time is 24 hours for those. We are challenged to meet that 24-hour turnaround time for all specimens, and it depends significantly on the daily volumes that are arriving in the lab. Asymptomatic results typically take longer than 24 hours and take up to 3 or even 4 days, depending on the volumes that we're experiencing. And upon completion, then the results made available to our public health teams. We are working to ramp up our capacity across this process to 4,000 tests a day by late December. A number of key items that are included in our approach to achieve that include diversifying our testing and lab processing options. We do have the high volume testing available in Regina and Saskatoon that process the bulk of our tests. And we've also deployed GeneXpert rapid testing at 19 locations across the province that provide more immediate results and support our clinical decision makers. We are in the process of deploying point-of-care rapid testing as well to support continuing care, acute care, and community rapid testing and also developing options for third-party testing. Within the labs themselves, we have enhanced our staff and resources significantly in order to address the increased capacity demands with 76 positions in various stages of recruitment and training. Many of those have been hired already and are in training or are actively contributing to the capacity right now. As well, we do have a wide availability of testing across the province with over 50 testing sites, as well as mobile testing teams that can support responses to outbreaks and other requirements. So once we go through the testing process, the next step is the contact tracing. And again, I'll just draw your attention to the process that generally depicts what we do when we get a positive test result. And so starting on the left with the arrival of that positive result, the first step is a rapid case notification, which occurs and is typically performed by a licensed healthcare worker in order to advise a person of the positive result and provide direction to them in terms of isolation and other activities that they need to do. Once that initial notification is completed, there would be a follow-up case investigation and elicitation of the contact names. Those two steps are performed by a public health nurse in order to fully investigate the case and draw information and provide the clinical direction as well. Once the contact names have been obtained, those are passed back to a licensed healthcare worker to perform initial notification of all the contacts that are related to the case, and they're advised to self-isolate. And then from that point, we do have ongoing active monitoring of the cases as well as monitoring of the contacts. Those last two steps we have assigned to unlicensed workers, which allow us to take advantage of other sources of human resources to support this process and the significant increases in demands that we're experiencing. So, and just pointing to the key strategies that we do have to support this process. We are using a contact tracing application that supports the overall process and reporting and ongoing monitoring. We have also worked to offload all of the notification of negative test results away from our busy public health teams and using other resources such as nursing students initially, and now moving towards having the Public Service Commission staff perform that as it's a non-clinical activity. We are also, as you can see through this process, by breaking out the specific roles and identifying who needs to do that and leveraging the scope of practice of the various individuals, we are able to better load level and ensure an appropriate skill task alignment of these key functions of contact tracing, and to do that across the province. We have sufficient public health nurses for over 450 cases a day if we ensure that they're doing the right jobs, which are those key points in case of investigation and gathering the contact names. We're also adding additional staff, be it licensed and certified staff that can perform the rapid case notification and initial notification of contacts. We are typically bringing those people into this process through service slowdowns in other areas, primary health care, ambulatory care, and others, in order to supplement the numbers that are supporting contact tracing. We're also adding significant numbers through our supplementary workforce, which is bringing in external agencies to help us out by adding personnel from the Public Service Commission, as well as federal employees from Stats Canada. We currently have over 100 Public Service Commission employees that are supporting the contact tracing as well as a few other processes, and the StatsCan staff are being onboarded right now. We're also using service slowdowns as required in order to supplement those steps. I do want to just pause for a second and just draw attention to the time required for this contact tracing to put it in context. Scott mentioned a bit of this in his opening remarks. Every single positive case creates hours and hours of work for our team at various steps throughout this process that I've described to you. You can appreciate that as the number of cases arrive and the number of contacts associated with each one of those, how the number, then the amount of work just exponentially increases. We have had some case investigations that ended up yielding 150 contacts for a single case. And our latest average contacts per positive case is 7.7. If we continue to average 200 cases per day, that average will result in just over 32,000 hours of work over 2 weeks. That's an average of just under 2,300 hours of work per day just on contact tracing. If these messages grow, the numbers, of course, multiply. The main message here is if people don't limit their contacts, then the numbers will continue to increase and place significant strains on our capacity. And further, I'll just note that this doesn't include the negative callbacks, which are important in terms of advising people of the results of their test. Today, we spend approximately 16,000 hours on negative callbacks, and it's just as one example, the day that we hit 4,500 tests, the day that we do hit 4,500 tests, we will create about 200 hours of work just for those that are doing the negative callbacks the next day. And of course, this increases as the demand increases. But I think you can appreciate that it's a 7-day-a-week process. It doesn't take breaks for the weekends, and is a major challenge in terms of the overall volume of work. The third plank that I want to speak to today in our offensive strategy is protecting our vulnerable populations. In the moment right now, as of yesterday, we had 76 cases in long-term care, when one case in long-term care is too many. It's a very vulnerable population, as we've seen from other jurisdictions. We have 27 outbreaks in facilities serving seniors or community-based organizations serving vulnerable clients, when, again, one outbreak amongst those populations is too many. Community-acquired COVID is getting into our healthcare facilities, impacting our staff as they need to isolate and eroding our ability to serve vulnerable populations. Key strategies in this area include visitor restrictions, and we're very aware of the impact that these have on family and friends that want to stay connected with their loved ones that are in our facilities. We are also employ robust screening processes in our facilities, as well as staff cohorting to limit their staff from working in more than one facility. We try to minimize healthcare worker exposure at all times, and safety is our #1 priority, and the PPE practices is a significant part of that. We are continuously improving our outbreak protocols and education to our staff and leaders. We have and are continuing to use assisted self-isolation as well as secure isolation as a means to allow vulnerable populations that aren't able to self-isolate on their own to do so appropriately. And we're expanding point-of-care testing options, as I mentioned, into long-term care and other areas, which will support our immediate responses in those environments. We also have mobile testing teams that are being deployed where they're needed, such as we've seen at the Lighthouse in Saskatoon. A key message here is that in order to save lives amongst those who are most vulnerable, we need the public to help stop the spread. I'm going to turn our attention now from the offensive strategy to our defense. Our defensive strategy essentially focuses on our acute response in our acute facilities. Our goal is to adapt and expand to meet projected COVID demand while also maintaining essential services to non-COVID patients. A number of key strategies that help us achieve this goal is developing surge acute capacity through the use of surge spaces in our existing facilities, as well as the creation of a field hospital in Saskatoon and one in Regina. We also employ a combination of mixed hospitals, as well as COVID and non-COVID hospitals that would be assigned those designations where warranted as the case numbers increase. Also, we have identified a certain number of hospitals that would convert to alternate level of care where required. I'll speak to that a bit more coming up. We also have field hospitals, the ability for them to expand further if required. We are maintaining a significant number of ventilators to ensure we have capacity to meet a peak demand scenario. And we are maintaining over 6 months of supplies of key personal protective equipment. As we go forward, we will continuously adjust and adapt the strategy based on modeling information that we've received and other circumstances that may arise. And I'll just point to the diagram in the bottom right, which tries to summarize our overall approach to this. We have a demand curve, which is meant to represent the increasing demand of a COVID wave, and then our overlaying on top of that are capacity steps, whereby as we forecast demand to be increasing, we would, in step with that demand, but always staying 2 steps ahead of it, increase our capacity in order to ensure that we're able to provide the continuation of services. So how are we doing right now? So just looking at our current state and comparing it to where we were in the spring. In the spring, when we had the first wave, we had a system-wide slowdown of non-essential services, which resulted in the creation of capacity in our medical wards, slowing down elective surgeries and others, and gave us some capacity to be able to immediately meet any potential needs as well as reallocate staff. Right now, we don't have that level of capacity. In fact, we're pretty much at capacity across the system. Our current average daily ICU demand across the province is at 97.3% of ICU capacity. We have significant ongoing capacity challenges in Saskatoon with our inpatient demand at about 105% of capacity and our current daily ICU demand at 126% capacity. So building on that, when we look out at a potential surge and what requirements, we have planned for surge up to 1,324 COVID acute care patients. So this number, just to put it in context, it represents about 61% of our current state acute capacity across the entire system. So in order to meet this, our approach would essentially be to draw down on a number of different service areas like elective surgeries, non-essential, non-urgent surgeries, and other services in order to create capacity within our existing facilities, as well as expand into field hospital locations through the redeployment of people that are made available by service slowdowns. Likewise, looking at our ICU in our planned scenario, we have planned for 412 COVID ICU patients. So that number represents a staggering 449% of our current state ICU capacity. It's a very significant number. And going hand in hand with that is 403 vented patients. And so we do have vents available to meet that number. Our major challenge with this would be the staffing that goes along with meeting all of these requirements, all of the surge plans. While we have identified spaces to surge into to meet these numbers, the staffing that go along with them will be an ongoing challenge for us. So as I mentioned with the pictorial, where we have a stepped approach to creating capacity where we stay in front of the demand curve, we do that both at the local level within a facility, stepping a response of cohorting patients into a wing or onto a unit, cohorting those COVID patients in order to reduce the risk of transmission and spread. We also do that at a facility level. In the north, we are applying a strategy where a number of hospitals would be identified as mixed hospitals, where they would serve both COVID and non-COVID patients. COVID patients, as I mentioned, would be cohorted in certain areas within those facilities. Other hospitals would be identified as non-COVID hospitals, and they wouldn't admit any COVID patients, and those COVID patients would be moved to one of the mixed hospitals or another hospital within the system. In our rural areas, we've adopted an approach where, similar to the north where we have non-COVID hospitals, we've also decided to potentially identify some hospitals as COVID hospitals. So all of these designations as COVID or non-COVID, they would only be activated as required in response to the actual demand that we would be experiencing. So this is not necessarily in effect in the moment right now, although we are certainly starting to move in this direction in some areas. But they would be applied as in response to the actual demand. So COVID hospitals would be identified as serving only COVID patients at a certain moment, and non-COVID patients will be moved to non-COVID hospitals. In addition to COVID and non-COVID hospital designation, we also have a number of community hospitals that would be converted to providing only alternate level of care services. Alternate level of care essentially represents a group of patients that include individuals typically waiting for long-term care placement, as well as waiting for other services that might not be immediately available in the community, like convalescence and rehab type services. Typically, ALC, as it's known as, patients would require a lower intensity of care than what is provided in an acute environment. By cohorting ALC patients, as we're planning to in this with this approach, it allows us to redeploy staff to areas where they are providing a higher intensity of care. It also allows us to move ALC patients out of other locations in order to create capacity in the system. I'd like to speak to the two field hospitals that have been created in Saskatoon and Regina. The field hospitals are essentially meant to serve patients that don't require the level of service offered in an acute setting, but still need ongoing service such as monitoring or oxygen or other level of care. We have essentially at this point completed infrastructure preparations for both of these sites, as well as having equipment available and have an activation plan within a certain period of time in order to have the field hospitals in either location up and running. We do have the ability to expand into additional capacity, again, based on a trigger point to start creating those additional beds. We do know that in order to scale up to delivering services in a field hospital would require significant slowdown of services. And I'll just point out the field hospitals, they are a last resort option. We would only see us admitting patients into field hospitals when we have used every other step in our response plan, every other surge space. So we've designated significant portions of our hospitals as COVID hospitals. We've moved into spaces like rehab spaces or therapy spaces, other outpatient spaces in our existing hospitals, and we're at the point where the only available option is moving into a field hospital environment. So it's basically a last resort option. I'm just going to walk through some of the key challenges that we are facing on an ongoing basis, as well as those that we anticipate as we move forward with implementation in our response. We recognize the ongoing strain and stress that the pandemic has had on our frontline healthcare workers who come to work every day to serve our patients and residents in a very difficult environment, and this is enduring throughout the pandemic. And throughout this, our staff and physicians, they are our key resource in all of this response. We are very concerned about the potential for ongoing exponential growth of the virus outpacing our ability to scale up and meet it, basically having our steps stay 1 or 2 steps ahead of that demand curve. Part of that is related to our capacity and availability of human resources. We have experienced basically a drawdown of the labor pool that was established earlier in the year as we resumed services. Virtually all of the personnel required are typically highly skilled, and it's not as simple as going to the labor market and bringing in additional people, although we are certainly accessing that as much as we possibly can. We struggle, and we anticipate this will be an ongoing challenge with high absentee rates from staff that are required to isolate either because they're positive or because they are a contact to a positive case and therefore need to miss work. And so this, I can't overemphasize this in its importance. It's not just the positive cases that disrupt our services by demanding the care, be it on the offensive strategy or in our hospitals. It's also the ongoing community transmission that ends up impacting one of our staff and basically takes them out of our workforce, as well as any others that were impacted by it. And I'll just mention that as an example of this, recently in a medium-sized facility, upon notification of a staff member becoming positive through community transmission, it basically in a moment's notice took out 15% of their workforce. So in a smaller facility, that can basically devastate the services that they're providing, and it's with zero notice. So we have the major challenge of trying to surge resources to supplement the workforce in order to be able to sustain that existing or reduced service in those locations. Part of the challenge as well is that it's not just one location in the province that experiences that. It's multiple facilities and communities spread across the province that are experiencing this concurrently, which again impacts our ability to respond. And this is happening in long-term care facilities. It's happening in our hospitals, and we expect that it will continue to be a major challenge for us as we move forward. As well, in terms of our human resources, we are going through processes to onboard a new staff, to bring on supplementary workforce, and that is creating a lot of churn within our own staff, and also it's a major resource draw to bring them on and get them trained and up to speed. Another challenge that we need to be able to manage, and we're very sensitive to, is balancing the COVID response with maintaining our non-COVID services. So we know that a key part of our strategy is to be able to slow down services in order to save lives and protect our health system. But as we draw down services, reduce them, there is an accompanying negative impact because people can't access the everyday care that they need from our system. I'm going to talk a little bit more about our system redeployment plan as well as the service slowdowns. So different types of slowdowns that we are employing right now and that we are going to be doing on a larger scale and greater number as we go forward in the days and weeks ahead. They include a reduction in services. So in some areas we may reduce the level of service that's being provided by which allows us to redeploy maybe some of the staff to another activity as part of the COVID response. So this may result in those programs providing only essential or urgent services. We may adapt a service by providing that service virtually through another means, or with the alternate level of care facility conversions that I discussed, or we may temporarily stop providing the service. All of our slowdowns are meant to be localized, targeted, and as time limited as possible, because as I mentioned, we are very aware of the impact they have on our patients. A few examples that have actually been implemented to date include some lower risk routine public health inspections, localized and time-limited surgical slowdowns. We have examples in Lloydminster and St. Paul's Hospital in Saskatoon where a healthcare worker case resulted in us having to slow down surgeries in both of those facilities. Reducing selected services in primary health care in some areas. Also, likewise, non-essential acute services like ambulatory and specialty programs, and non-essential continuing care programs like some of the active living programs that are offered. We expect, and we're experiencing as we speak, that we are going to be implementing similar service slowdowns as we go forward in the coming days and weeks. Over the longer term, we are continuing to assess our need to slow down or resume services based on the modeling and the case trajectory that we're experiencing. We are taking what we refer to as our dimmer switch approach over the long term, where we can scale up and scale down services as required in order to ensure that we can provide a robust response to COVID, but also be able to sustain non-COVID services as much as we can. We expect that changes in service delivery, they may not happen the same in all areas. We may see some service reduction in some areas, and whereas others are not experiencing that, and that's based on the local demand, as well as how they're best able to respond and with their respective surge plan. Also, I will mention that the rapid and effective distribution and delivery of the COVID vaccine through the various prioritized key populations is underway, being led by the Ministry of Health. Key messages that I'd like to emphasize today include the safety of our patients, our residents, and our healthcare workers is our #1 priority throughout the pandemic. We are committed to maintaining non-COVID services as much as possible and keeping service disruptions as localized, targeted, and time-limited as possible. We will stage our surges and our slowdowns in order to meet demand. At the end of the day, we know that protecting the healthcare system is ultimately in the public's hands, and we need your help. At this point, I'll turn it back over to Scott.
Thanks, Derek, and we'll get to questions in just a minute. I just have some closing remarks. Early last spring, Dr. Shaw, who is actually on the line with us, wrote an editorial stating publicly that no health system in the world could withstand the pressure of COVID-19 left unchecked. As we see cases surge here in our province, I think there's no better time to remind people of that editorial and the warning. While we do have checks in place, they need to be abided by, and we need Saskatchewan residents to do everything they can to help us fight COVID-19. We can make plans, but as Dr. Shaw said, like the Rough Riders, we need our 13th man. We need help from the public to help control and contain the virus. In fact, people know that Dr. Shaw is part of our executive leadership team at the Saskatchewan Health Authority, but she also is a practicing critical care physician. I believe she just came off shift at St. Paul's Hospital today and is now joining us. And all I'd like to say is that if Saskatchewan residents would let this go unchecked, we would be sending Dr. Shaw and thousands of frontline workers in our healthcare system into a lion's den. We'd be sending them to deal with exponentially more hospitalizations, more ICU admissions, and certainly more deaths. We'd be asking them to have more conversations with families whose loved ones aren't going to make it, and we'd be sending a signal that our comfort is more important than theirs, and that their lives and the lives that they're trying to protect are less important than ours. We need to send a different signal. Let's double down. Let's start supporting public health orders. Let's start crushing this virus and numbers of contacts. We need your support to help do that. If this number does not shrink, the health system is surely going to struggle with respect to both our COVID and our non-COVID loads, as Derek has outlined today. And despite our best planning, it would be inevitable for us to be overcome if we do not get the virus in check as quickly as we can. So in closing, I'd just like to say again, shrink your bubbles as small as possible. Wash your hands regularly. Don't go to work or out in public if you're ill unless you're going to seek medical attention. Abide by all public health restrictions, and please wear a mask if you're in public. And with that, we'll open up the floor for questions.
Thanks, Scott. We'll move to question and answers. I've got a few folks in the room with me as well as some on the phone. If you're in the room with me, you can either come up to the mic to ask your question, or I'll do my best to interpret for you so that the folks on the phone can also hear your question. So I've got one in the room. Arthur, would you like to go ahead?
So first question would be for Dr. Shaw, who I think you said is on the line. I just was hoping you could give me some insight about what 26% capacity in Saskatoon ICUs looks like. How is that affecting your job? How is it affecting your ability to care for patients? Just kind of take us through what it looks like.
Thank you, Arthur. So what it looks like is ICUs do flex and fluctuate with how many people we look after. What we're seeing right now is above our usual numbers of patients and numbers of staff, we have more patients. So we have to have more staff to do safe care. I myself this week worked 2 extra day shifts directly because of the increased numbers, and I'm not alone in taking on extra clinical work. I would say our staff are doing really well, and we are tired. People are really sick. They require a lot of care, and we are there for them, and we want to be able to be there for them. We do have additional plans to be able to increase how many more people we can look after safely. But as Derek said, and as Scott said, we can have machines, we can have space, we can have equipment, but what patients really need is staff, and they need nurses, they need doctors, respiratory therapists, pharmacists, physiotherapists, dietitians, housekeepers, special care aides, continuing care aides. Like, these are the biggest resource we have, and they're our biggest asset. So what it looks like, what it feels like, is something I've never seen before. I've worked for 20 years in intensive care units. I worked in Saskatchewan and out of the country, and this is a sustained increase in very sick people for the longest period of time that I think we've ever seen, and we know it's going to continue for the weeks to come, and we really need the public to stay home, keep your bubbles small, and stay as safe as you can by following every single public health measure.
Do you have a follow-up?
This is for both Dr. Shaw and for Mr. Livingstone. You've both been very forceful in calling on the public to follow the public health orders, kind of, advocating for the health system with the public. And I'm just wondering if you're conveying that same message to the government, and if you can give us a sense of what you've been calling for from them in terms of resources, in terms of stronger public health measures as they try to balance off the needs of the health system with the needs of the economy. What kind of message have you been taking to the government?
Well, I'll start, Arthur. And again, you highlight that, as part of the offensive strategy, which we highlighted again in the health system plan, it's really that 3-legged stool of contact tracing, testing, and public health orders that together work to help us control the virus. And our medical health officers and clinical teams work very closely with Dr. Shahab's team around looking at what the current restrictions are delivering with respect to what we're seeing in COVID. We see cases in a different way than we did before. That we're seeing large scale community-based transmission, and that's a much more complex problem for us, and including it's a much more complex problem to actually contain with a single public health order or a single rule. It's not one thing. It's a series of multiple components that are going to help us get there, and we've done it. We did it at the beginning of this, and we know how to do it. We've got lessons learned. We know more things about the virus with respect to how it's treated. We know more things about some of the successes around how we distribute work across the organization. But the reality is that if we don't work those 3 legs, we can have all the resources, in testing and contact tracing that we would ever wish for, work towards 300, 400, 500 cases a day, and it will be for naught, because if we don't have people who are moving the virus around the province stopping to do that, we simply will not be successful. Susan, did you have anything to add?
I don't think so. I think we continue to have meaningful conversations and about what we're seeing, what we're concerned about, and we'll continue to do that. It's just imperative that we all work together for the same goal. COVID is everywhere. COVID is job one for us in the healthcare system, and it has to be job number one for every single person. I can tell you it's so frustrating when I get emails, I get letters, I get phone calls, I get texts, I get tweets by people saying this isn't real, you're exaggerating, it's not really happening, why are you doing this to us? I just have to say, it is so real. I cannot tell you enough how real this is. And we need everybody to see this as job number one.
Can we take a question from the line, please?
We have Ryan Kessler with Global.
Good afternoon. When it comes to addressing the need for ICU spaces, what is the larger challenge here? Is it the adequate staffing, or is it literal beds and space for COVID-19 patients?
So I'll start, but again, I'll probably turn it over to Derek and Susan. So I think what's been highlighted throughout the presentation is with respect to our physical capacity, whether that's PPE equipment, the number of beds in the system, we can redeploy beds into more acute care or even in ICU as long as we have the staff to be able to care for folks. So the number one thing, as Susan has highlighted, is having appropriate trained, skilled staff to care for folks. And the limit on that is at the same time we are trying to provide both COVID and non-COVID services, is we will redirect resources to care for the sickest individuals, and if that happens to be a high level, a number of admissions related to COVID and ICU admissions in particular, that's where the resources will go. But that comes with a cost, and there would be a breaking point at some point in time. I mean, where decisions like we were seeing in Europe with respect to healthcare, frontline workers, physicians making choices, ethical choices of who they were treating and how they were caring for. It's really like, if it comes to that point where we're talking about completely being overwhelmed, those are wartime conditions. Those are not normal healthcare, everyday service conditions. And that's what the risk is with not containing the virus. Susan, did you have anything to add?
No, thank you, Scott.
Is there a follow-up, Ryan?
There is, and I appreciate it's described as a last case scenario, but is there a firm number or a metric specifically that needs to be reached in order to open a field hospital?
No, I wish I could tell you that this is the trigger that says field hospitals open, but what it is it's a combination of things, and Derek highlighted it in the defensive strategy. It's really that stepwise approach, and how do we systematically look at what we're seeing today, what we're forecasting for the days and weeks to come, and it's those triggers with respect to what's happening in the system overall, where we're starting to move capacity to a level where it's getting so uncomfortable that we have to activate field hospitals. And we do have a strategy for doing that, but it's not a day, a single day decision where we're going to say it's time to light them up. It's going to be looking at what's coming down the pipe, understanding that there's a lag time with hospitalizations, ICU admissions, and deaths from when a positive case is identified. The daily positive cases are really the tip of the iceberg from what's going on underneath that, and that's what we will use to actually trigger and build out, staff out the field hospitals. And I just ask if Derek had anything to add to that answer.
Nothing to add, Scott. Thank you.
We're going to take a question in the room next.
Hi, I'm wondering what the average for contact tracing is for someone to get a call, how that works based on the numbers and how many people are being tested and now traced. And we're talking about there's a bit of a backup, there's a lot of people. So if someone's getting a call, how long can they expect, or getting a test, how long can they expect to be called by a contact tracer?
Yep. So again, we in the two of the slides today, both the contact tracing and the testing slide, sort of broke it up into those multiple components of when a test result is delivered to a patient, and so there's lots of things that happen before a test is actually run, including patients being swabbed all over the province, 50 different sites, plus the drive-throughs, getting those to the lab, processing those results, and then once a positive result is generated, and that can take some time. So we have short time frames in, for example, Saskatoon and Regina, where we can transport the swabs to the larger centers very quickly. But if the test swab is coming from La Loche or an outlying area, it takes more time. So it varies. Our target, and so once a positive result is generated, it's 24 hours that positive COVID results are delivered to patients, and that process is started around close contacts. For non-positive patients, that negative callback, that's a longer period of time. It can take up to 72 hours to notify somebody that they're negative, because we are focusing on the positive. But as I said, we are increasing resources around both of those things to try to expedite that care. But the real time frames around, the testing and contact tracing there isn't a single number, because it's not one path. And the other thing I would just highlight, one of the challenges with contact tracing, and we talk about the number of contacts, but people have to actually pick up their phone and be available. So it's not you don't nail it every single time. So that it's not just the number of contacts, it's how many times do we have to reach out and contact. And then once they're identified, they're being contacted each and every day. And there's questions that would ask to try to trigger memory on what other contacts they may have had in the past that weren't identified on the first call, right? So that's an ongoing process.
Follow-up?
Yeah. We're hearing stories in Saskatoon and Regina, the drive-through testing, about people, using the bathroom outside in the snow because they're waiting so long.
Yep.
And they may have their kids in the car for 3 or 4 hours. I know you sent a release out about a difference, but is there a move to go to symptomatic testing, to get people that are tested that are close contacts, to try and shrink the number of people that are seeking a test? How are we dealing with this? I guess in some days it can be overwhelmed by these tests.
Yeah. So just go back, to your question specific about the drive-through testing, and we're aware of, those days where we have backlogs and we're turning people away, or people are waiting so long. We're hearing those instances as well, and we are working on a strategy on all of on both Saskatoon and Regina in particular, where we're hearing that. But as you know, we do have drive-through testing available in Yorkton, and we're going to expand that in PA. We learned very quickly that when we went to drive-through, it was a very popular option for folks, and it often doesn't have a single individual in a car coming through, so there are multiple individuals. So we're working on how do we actually build that capacity. With respect to continue to build more capacity, because the other thing I would say is it's not the same number of people coming each and every day, so it's hard to say, we need to build out to have 1,000 test capacity a day in Saskatoon or Regina, and then the next day only 400 people show up, and then those are resources that we could use someplace else in the system to actually support the COVID response. But we're working through that and looking at how we expand that. It's likely that we would have to pull other resources out of other areas, as Derek has pointed, to actually staff that and support it, but that's a priority for us with the offensive strategy. The other thing is with respect to symptomatic and asymptomatic testing, as you know, on July 14th when we opened it up, testing across the province, and continue to do that, although we do prioritize symptomatic cases that are close contacts of symptomatics. We still are doing a large amount of asymptomatic testing in the province of Saskatchewan, where other jurisdictions have not done that. But at this point in time, we're not talking about backing off on that, and it's related to when we see this large-scale community spread, that asymptomatic testing starts to see more cases coming up. I think at the start we're seeing maybe, I don't even know what the numbers are, about 1% of the asymptomatics might have come out positive. So is it a good bang for your buck? But I know that's creeping up with community spread.
We're going to go to a question on the line, please.
We have Lara Feminov with CQM.
Hi there. Thank you very much for taking my call. This is a little bit of a different topic, but I was wondering whether any of you had knowledge of a large wedding expected to take place this weekend on a Hatarian colony that could see anywhere between 50 and 300 people attending. It's something that I have independently confirmed.
I can tell you that I have no knowledge of a planned wedding on a Hutterite colony this weekend, and I'll open it up to Derek or Susan, but I'm sure that they wouldn't either. But go ahead, Derek.
No, I'm not aware. But
Is there a follow-up, Laura?
Yes. If you did, if information does come to you about a large-scale event that is expected to go ahead, what are the steps that public health takes in order to research that and or put a stop to it?
So I'll give you what's happened in the cases of, where we've seen some of this stuff happen over the summer. I mean, typically, we start with an educational approach, and if we're made aware of a large event, whether that's a mass gathering for whatever purpose, typically public health inspectors would come out and have conversations with the organizers about what they're doing and how what they're doing or planning would fit or not fit current public health orders, and if it was obvious that the event was not meeting current public health orders, the event organizers would be advised as such, and there would be recommendations from public health inspectors to not go ahead with that event. If it did go to event and there's a violation of components of Public Health Act or multiple components of the Public Health Act, there are remedies with respect to fines, but again, you're asking a hypothetical question, so I'm giving you an answer with respect to what typically would happen, but without knowing all the specifics, I'll leave it at that.
We'll go to a question in the room, please.
Yeah. I just want to, it's a clarification. Last Thursday you said that the average positive case had 11 contacts, and today we're hearing that 7.7. So does that represent a good sign that in the past week or so people have started to reduce the amount that they are socializing?
So good question, and I just want to clarify. So when we went back to 11, that was sort of a point in time that day. The numbers we're talking about today are more around a 2-week rolling average. So over a 2-week rolling average, we're seeing it, so I think Derek mentioned that the number that we're seeing is 7.7. So the 2-week rolling average preceding was 8.5. So it's not an 11 to 7.7, it's a 8.5 to 7.7, and it's still early, but that is positive because it's not going up. But there's a lot of other metrics, as you know, Stephanie, like with respect to the case positivity rate and testing, which is another number that Dr. Shahab often speaks a lot to, that it is still concerning because it's high.
Are we seeing a bit of a growth or spread of this virus at all tied to just how overwhelmed contact tracers are? Like they're not able to necessarily identify people in time, or it's maybe taking a few extra days or hours before they say, hey, you should be self-isolating or you've been in contact with somebody positive? Like, I'm wondering if there's a bit of a chicken and egg going on here.
Yeah, I don't know the answer to that question. I would say that, although we are pushing the seams on contact tracing, relative to other jurisdictions, we are still in good shape, and I wouldn't say no, that absolutely couldn't happen, because but I don't know, and I know Dr. Shahab is on the line, and I would just ask if Dr. Shahab had anything to add.
Hi, thank you. So I can speak to 2 or 3 points that were raised. First of all, I'll just say that if there's any information about possible or past non-compliance with the current public health order or the new public health order that goes into effect tonight, where you cannot have any gathering of more than 30, and even in that, food cannot be served. So just want to be clear, gatherings of up to 150 were allowed in places of worship or other ceremonies. Gatherings in public places in the past could be up to 30, where food could be served in a safe manner, no buffets, but plated food. As of today, whether it's a place of worship, a wedding or funeral can have more than 30 people, and there can be no food service. So if anyone has any information on that, there is a public health order non-compliance reporting form, where reports can be made. There's the Saskatchewan Public Health Safety number. So, it is important to report non-compliance. And I would also like to submit that the time for education is now mostly over. Any egregious non-compliance will and should be met by through fines and other measures. So that's number one. Number two, with the new measures that come into effect now, if you look at them closely, it minimizes, as far as we can state, the chance of anyone having more than a reasonable number of contacts. But having said that, like Dr. Shaw has said, we have to then abide by those general guidelines and the orders. If we look at, ways to circumvent them, then I'm afraid, we would be heading into dangerous territory both for the healthcare system and potentially for a full lockdown. So if you want to avoid a full societal lockdown with all the social and economic costs and mental health costs that entails, and don't want to overrun the health system, we must follow now closely the public health guidelines. And I have said before, and I'll say again, we must on a daily basis say how many contacts, close contacts did I have over the last 3 days. And you should go about your business, whether you're going to work or you're going grocery shopping or you're providing other services, in a way that you should be able to confidently state that you had no close contacts because you kept the appropriate distance and you were wearing a reusable medical mask and so on, but that you had some contacts would be considered non-close contacts and would have to be undergo monitoring. So I think this is essential. We all need to understand what's a close contact, what's not a close contact, and we need to go about our daily business, which is as per the current guidelines and orders in effect, where we should really have virtually no close contacts on a day-to-day basis, whether we are in a workplace, whether we are exercising in a gym. The guidelines are designed to minimize that eventuality. Thank you.
I just have one final clarification question. We heard that there were some positive cases that had like 150 contacts. Like, how many times has that happened? And can you qualify that? Like, are we talking about someone who might have been a doctor who, has just seen a lot of people, or is this cases of individuals simply like socializing that much?
General information, but we can get some specific information with. If in the healthcare environment, if appropriate PPE is being worn, if seeing patients is not considered close contact. And I would also like to state that further to Dr. Shaw's comments, many people in the front lines, including many healthcare workers, have actually been significantly limiting their social activities over the last 9 months. So not just sacrificing in terms of work, but sacrificing in terms of the personal lives of themselves and their families, because they want to minimize exposure in the community setting. So I think, the people who work in essential services have in many cases been carrying a double burden of a severely restricted social life, even when many things were allowed, which are now not allowed, as well as, obviously continuing to care for people with COVID. But having said that, some of the large numbers of contacts were in situations where people may have gone to multiple social events or gatherings. We do know that over Halloween and Thanksgiving, in some instances, people went to multiple events while symptomatic, which was, technically allowed, but, I would say unacceptable that you are symptomatic and you're going into multiple events or gatherings of 15, generating dozens of contacts. Similarly, in workplaces, where COVID protocols were not strong, in some places there were, a larger number of contacts, and that now has been addressed through a clear direction from Occupational Health and Labor that every employer must have COVID protocols in place. So, and again, gathering limits now are less than 30. So we have had super spreader events in various settings, including places of worship, other settings where, transmission happened, nightclubs. Those are no longer allowed. So we would expect that we would not see a situation where, first of all, we should all behave in a way that even if we were to test positive or the 2 days prior to symptom onset, we should reliably be able to say that we had no or very few, less than 5 close contacts. And if we can't say that, there's an issue with how, we are conducting ourselves or with the protocols. And beyond that, we should have very few non-close contacts who would have to self-monitor as well. Thank you.
We have time for one last question on the phones, please.
We have Brian Zinchuk with Glacier Media.
Dr. Shahab, the case count average for 7 days is now 243, which means that we have yet again doubled from 120 to 240 over 16 days. And we are continuing on this exponential growth, basically doubling every 2 weeks for the past several months. Manitoba appears to have flattened out, and North Dakota seems to have curved downward in the past 2 weeks. So can you speak to what's happening in Saskatchewan versus those?
Dr. Shahab, did you hear the question?
Yes, thank you. Thank you for that question. So you're absolutely right. We must look at weekly averages, and all our indicators are still trending upwards. So our daily new cases per 100,000 is 243. Case rate per 100,000 is 20. And I've said anything above 10 is cause for concern, and we have to take actions to reverse that. Test positive rate is 7.2. So these trends are heading in the wrong direction. We have had a few days with much higher cases, some days with lower cases, some days like today, maybe in part due to enhanced testing, for example, in long-term care facilities, personal care homes, corrections. So sometimes when you do enhanced testing as part of an outbreak investigation, you generate additional cases. But nevertheless, I think there's no doubt that our overall case numbers are unsustainable. They are leading us into dangerous territory. And if our case numbers don't stabilize over the next 2 weeks, further restrictive measures would be required. Thank you.
Is there a follow-up, Brian?
Yes, for Mr. Livingston there. Now, my wife's a nurse, and my late sister was also a nurse. And my understanding is that through most of Saskatchewan's healthcare system, almost every ward has permanent part-time staff or casual staff throughout the system. How many of these people have you brought on to full-time status? That people that may be working 3/4 FTE or half FTE? Because you mentioned a lot about the need for people. How many of these people are now full-time or overtime?
So I don't know the answer to your question, but I will say this, that there are lots of people that work in our system that choose to be part-time or casual employees, and just because they are part-time or casual employees, it certainly doesn't mean that they don't work full-time hours. We have lots of staff across the province that work full-time and more than full-time hours that are part-time and casual. I will say that over the course of the pandemic, with respect to offering new roles, there's been a number of new roles posted. We've filled over 570 positions that are full-time temporary positions across the sector, and we will continue to do so. But I don't know the overall answer to your question, and I'm not sure that given the fact that many people choose to work part-time or casual, that's even an answer I can give you.
That's all the time we have for today. Thank you.
Thank you.